Good morning, everyone. Thank you for coming during the Labor Day. Today we have a pleasure to receive Dr. Ramos and Dr. Barros. Dr. Ramos is a Brazilian trauma surgeon from Adão Pereira Nunes Hospital, and Dr. Barros is a PGY2 at the same hospital. Thank you for coming.
Thank you, Patricia, for the presentation. Can you start?
Yes, you can.
Okay, so good morning, everyone. Thank you for joining the group today. As you already know, my name is Hamilton Barros. I'm a second-year resident of the Hospital Adão Pereira Nunes in Rio de Janeiro. And this is the presentation that we're going to start right now. Well, the case, it begins with a male patient, GCC, 22 years old. He was shot and taken to a hospital without a trauma center. At this primary hospital, he received a first approach with urinary catheterization. The patient was intubated. He received 1 liter of crystalloid and a femoral access. Unfortunately, we don't know how was the patient conditions and why he was intubated, but that's the relate that we have. The patient arrived to us in our trauma center at 15 to 1 o'clock, 90 minutes after the original injury. And we had known that he had an entrance injury below the 12th right rib in the back, and an exit hole in the mid-clavicular line about the 4th intercostal space, with a lesion with 10 centimeters of diameter. The physical examination.
Sorry, we don't have that picture, okay?
Yes.
Just to explain, we don't have the picture of the exit wound.
The physical examination.
Excuse me. Did the bullet traverse the mediastinum? Is it from left to right?
No.
Left?
No. Right to right. Right in the back and right in the front chest.
Okay, thank you.
Okay. You're welcome. So the physical examination, the patient in letter A, he had an endotracheal tube and a mechanical ventilation. He had a right open pneumothorax with a preserved vesical murmur at left hemithorax, saturation 95%. In the circulation, he had a blood pressure 80 by 60 and heart rate 125 with no active bleeding. He had a pupillary light reflex bilateral normal and an anterior right chest wall destruction about 10 centimeters of diameter with a visible lung parenchyma through the lesion and a palpable rib fractures. He had, as you already know, a punctural lesion right in the back under the 12th rib. So after this initial examination, I would like to know, Patricia, if you can help now, what should you do? What about the initial assessment? Would you think about resuscitation maneuvers? And what would you have done during this ABCDE?
Thank you, Dr. Barros. Dr. Antrak, do you have any consideration? Do you have?
Well, yeah, so he's got good access in the groin, apparently, and I would put another intravenous catheter in one of the upper extremities, so you have access above and below the diaphragm. You have to activate massive transfusion protocol, give him a couple of units of packed cells to see if he responds and remains stable, or whether he's a transient responder or a non-responder. You need to do that rather quickly. In the chest, he's got an open sucking chest wound, an open pneumothorax, and he's on a ventilator. So the positive pressure ventilation should have maintained him en route. But in this case, I would put an occlusive dressing over the blown out area and a chest tube on the other side to see if how much blood is in the chest. And then also I would do an EFAST, basically look at the left chest, the pericardium, and look for bleeding in the abdomen to find out where he's lost all the blood to become to be in shock. Also, I don't know if you have any information about his status during the transport. How it was 90 minutes between the injury and arrival at your hospital, I assume. So it must have been probably at least 45 minutes, at least half that in transit from the other hospital. And I don't know if you have any information about his status en route, but basically needs to be to figure out very quickly where he's bleeding and then stop the bleeding in the operating room.
Thank you, Dr. Intl. Can you answer the question, Dr. Barros? Is like 90 minutes or not?
The transfers took 90 minutes. He arrived 90 minutes in the initial hospital, and the time until they assumed the patient and transferred to us, it took 90 minutes. I don't know exactly.
He wants to know if we have information about the transport. We don't.
No information
on the transportation.
The condition of the patient during the transportation. No, I don't know.
But anyway, it's assuming that either he was better and deteriorated en route, but it's a long time. If you assume the worst, that he was in shock the whole time, it's not very good. Or about urine output, if he was still producing urine when he got there. But anyway, so it's a patient where a lot of time has been lost and a serious injury. So it's that's a bit of a problem here, and it's time is of the essence. He needs better resuscitation and then definitive control of the bleeding.
Thank you, Dr.
Yes.
Mm-hmm.
So may I go on?
No.
No, the others.
Let me ask Dr. Cassim. Dr. Cassim, would you do something different?
Yes. So let me give you some of my thoughts. This is very poor trauma care, wherever he is coming from, the small hospital. It is, in fact, it is atrocious. And you need to correct this by teaching them what not to do and what to do in a trauma case like this. And of course, the paramount thing that you need to tell them would be, they cannot keep the patient for 90 minutes in the hospital or take 90 minutes for transportation. And moreover, they are not really doing anything good to this patient while he was in the hospital, such as at least put in a chest tube on the right side, perhaps on both sides, to see if there is any drainage from any of the chest cavity, because he's hypovolemic, no matter what. He is hypovolemic, and then he also has oxygen problem, and he may even have a tension pneumothorax. Who knows? Even though he has a open sucking wound, that doesn't mean he has evacuated everything from his right chest cavity. There may be still a problem there, and all these needs to be addressed. And I totally agree with Dr. Intl that I would put some type of sealant on the open chest wound. And I would immediately, when he arrives at my institution, I would think of hypovolemia, oxygen problem, and of course, intensive resuscitation. And I would do bilateral chest tube in this patient, and then I would go ahead and transfuse him, and with 2 units of blood, O negative if you don't have cross-matched blood, and stop all the crystalloid because it is not going to do any good to this patient. And perhaps you can get some response to this. I didn't know how old he was, but he looks like a young person. He may have responded to transfusion, at least transient, and then find out if he has other injuries. And chest X-ray would be very, very useful. And while you are there, you can also do an abdominal X-ray to see the trajectory of the bullet, to see where it is lying. And of course, fast examination would be very useful in this patient to see if he has any intra-abdominal injury causing his hypovolemia, or this is all in the chest. So to summarize this, it'll be HOT, H for hypovolemia, O for oxygen treatment, and T for transfusion. If you remember that, you will be at least halfway there. Thank you.
Thank you, Dr. Kassim.
Thank you.
Dr. Supa, do you have any considerations to make? Dr. Supa, can you hear me?
I missed the first part of the presentation, but looks like this patient got a shot from the right posterior, I'm sorry, from the left posterior chest to the anterior, and she is hypotensive, right?
Mm-hmm.
So in this case, I would agree with putting in the chest tube, see what comes out of the chest tube, and prepare for the transfusion and the thoracotomy. Thank you.
Thank you, Dr. Supa. Dr. Epstein, any comment?
Yes, I think there are several considerations. One, the gunshot is below or at the bottom of the right rib, which means the liver is right there. So this most likely went up through the liver, part one. Part two is venting him. If the pneumothorax on the right is considerable, he may have trouble with losing his ventilation to the right and may not be ventilated perfectly to the left. That would have to be part of the consideration. And of course, I agree with, I would put a chest tube on the right. I would see if he responds to a couple of units of blood. And then I would, if he responds, I would like to go to CAT scan just to assess the extent of the injuries. But I think that the liver is also concerned in this gunshot.
Thank you, Dr. Epstein. Dr. Barros, your turn. Thank you.
Yes.
Dr. Kassim, sometimes in these small hospitals, they don't have chest tubes. And people who work there, they don't know how to put on a chest tube. That's very likely to happen here. Yeah, it's complicated.
Let me interrupt and add one thing. What was he sedated with at the incoming hospital? I realize you have almost no information. So what was he sedated with to intubate? And was it still, did they give too large a dose that he was not awake, alert, etc.?
Camille?
Dr. Ramos?
Was midazolam, right?
Yes, midazolam. Normally they came with a midazolam in the dripping.
Yeah.
That's how it arrived to us.
Thank you, Dr. Ramos. And Dr. Barros, please.
Yes, so thank you all. So what we did, we started with some resuscitative measures with tranexamic acid. We could do 1 hemoconcentrate, calcium, and half liter of crystalloid fluids. We put a right chest tube, and with immediately 200 milliliters of blood after the insertion, and we had already an air leak. We closed the skin of the destruction of the chest wall, and at this time the patient had a vital signs with a blood pressure 96/50, saturation 98, and heart rate 132. We took a blood gas test too. The patient had a metabolic acidosis with a lactate 3 times in the upper limit, with a pH is 7.1, basic says -11, and a hemoglobin measure of 10. And then after these measures, what would you do? Knowing that the patient is a little bit more stable. Patricia is on your hands.
Thank you, Dr. Barros. Dr. Supa, would you do, can you please share your experience with a case like this?
I think fast would be a nice approach for this patient to check for intraperitoneal free fluid and peritoneal blood. If he has those two findings, I think would be enough to send the patient to the operating room for laparotomy or thoracotomy. And right chest tube output doesn't put out much at this moment, but we have to keep an eye on that. If fast, if fast is negative, I would go with a CT scan of the chest and abdomen if the patient is stable enough. But I would have low threshold to take this patient to the OR if the patient drops the blood pressure again. Thank you very much.
Thank you, Dr. Supa. Dr. Antrak, any consideration?
Yeah, right. So I agree. Certainly conservative management won't work. And in this case, it sounds more likely that the bleeding is going to be from the abdomen. 200 cc's out of the chest tube, if nothing more is coming out, that wouldn't be an indication for an operation. And by the anticipated trajectory, it would have gone through the liver, maybe the right kidney, then up in the chest only through lung. So likely, as Dr. Epstein said, to be from the liver. And I would certainly do the fast, expecting that it would be positive. The CT scan would be desirable, but with a pulse in the 130s and a blood pressure systolic of 98, it's not really. I think it would have to be better than that. The pulse would have to be coming down, but. You know, if it stayed like that, 98 systolic and pressure and pulse in the 130s, I would do a fast exam. If it was positive, straight to the OR, and if it was negative or equivocal, and he just wasn't getting better hemodynamically, I would still take him to the OR, do a midline laparotomy, and perhaps. Depending on what you found, I would maybe do if there's a lot of blood in the belly, fine. If not, I would do a subxiphoid pericardial window just to rule out a cardiac tamponade. But it's certainly the fast exam would be my preference. Look at the left chest, the pericardium, and the abdomen. You can also do if you have a minute, just do a chest X-ray just to be sure that both lungs are expanded and eliminate the concern that Dr. Epstein had about not oxygenating properly, not ventilating properly.
Thank you, Dr. Antrak. Dr. Epstein, could you please share your experience?
Sure. Actually, I agree. You know, I'm not sure that I would take him to CAT scan. I love CAT scans and gunshots. Sometimes you can treat a liver gunshot expectantly, although he doesn't seem to have the vital signs to want to treat this expectantly as well. If he had a kidney injury, he might have some hematuria, but if I'm going to go to CAT scan, the operating room is going to be ready, because one way or the other, you go to the operating room.
Okay. Thank you, Dr. Epstein. Dr. Cassin, any consideration?
The one thing I would not do, repeat, not do, send the patient to the CAT scan. If you want the patient to die, that's where you send the patient to CAT scan in a case like this. The single most important parameter that I'm looking at in this case is his tachycardia. He's young, he's compensated with his blood pressure, but his heart rate is 132, far too high to do anything other than he needs an operation. So I have learned from Dr. Supa, in a case like this, when you have a thoracoabdominal incision, take the patient to the operating room, position him in such a way that you have access to the abdomen, access to the chest. And first, I would do a laparotomy. Like Dr. Epstein has mentioned, that I am suspicious that he has a through and through bullet going through the liver, and that's where he's bleeding from. And that's where that I'm going to find my money. Thank you.
Thank you, Dr. Cassin. Dr. Barros, please, your turn.
Yeah, so what we did, we took some risks. The patient went through a CT scan, and what we found It's important to say that the ultrasound wasn't working this time in our hospital. And so we decided to do a CT scan, and that's what we saw. And we had no iodine contrast. There is another series. It's important to say that the drain was closed at this moment, unfortunately. So this pneumothorax is greater than the real one. And then, Patricia.
Thank you, Dr. Barros. Dr. Epstein, would you like to make any comment?
It looks to me like there is a liver injury. There's quite a bit of air along the mediastinum, and without counting those ribs, it looks like it's pretty low. So I would still go to the operating room and I would open the belly, unless I'm reading the CAT scan wrong.
Thank you, Dr. Epstein. Dr. Cassim? Any
Well, on the
different-
CAT scan, he's got fluid around the liver and also air. And so I would be suspicious that he has injury to the liver, bleeding around that. And I don't know where the air is coming from. Maybe the air is tracking downwards from the chest to the abdomen, which is not the usual thing to happen because air usually rises up. So he may have an injury to the diaphragm and injury to the lung as well as the liver. So liver is the area where we bleed more than the lung, and the chest, you have a chest tube and you need to remove the chest tube and put a new one in and just make sure that it's functioning. And I again would take the patient to the operating room and open the belly. That is where the money is. And then I would position him, like Dr. Super has taught us many times, in such a way that I would have access to the right chest cavity at the same time. Thank you.
Thank you, Dr. Cassim.
Conservative treatment is way out. Laparoscopy, no. What he needs is a laparotomy and a possible right thoracotomy if indicated.
Okay. Thank you, Dr. Cassim. Dr. Antrak, would you do something different?
No, I pretty much agree with all the comments. I'd like to ask what was his condition at this point after the CT scan?
The CT scan was immediately after the last vital signs I've shown you.
Yes. And now, so he's about the same? He's about the same. Is that right?
Yes,
better?
directly from the
Okay.
trauma bay to the CT scan.
Okay, so he didn't deteriorate, so I guess it worked out. But I agree that it's not in the chest. There's still, there's the pneumothorax, and there's still a fair bit of blood posteriorly at the base. And I would, as the other said, do a laparotomy, and then at the end of the case, you can put a better chest tube in, make sure you evacuate all the blood that's sitting in the right chest, get the lung fully expanded. But I think it's fine. You put him like in a semi-decubitus position, as if you can do a thoraco-abdominal incision. I think that's what Dr. Casa means. You can do basically thoraco-abdominal incision, but in this case, I think you'll probably manage to avoid a thoracotomy. But he needs an operation, because he's tachycardic and a little bit hypotensive, and I think it's in the belly.
Thank you, Dr. Antrak. Dr. Super, any consideration to make?
In this patient, right thoracotomy would be necessary if the patient has persistent air leak or massive bleeding from the right chest. Was he having a lot of air leak from the chest tube at that point? Dr. Barros?
Dr. Barros, can you ask, please?
Yes, the output of blood stopped around 200 milliliters, with no blood no more blood in the situation, and we had a continuous air leak. Yes, we had it.
If the patient has like a continuous air leaking, I think he may need also the right thoracotomy because he may have major airway injury or the large hole in the lung. Especially if he couldn't keep his saturation above 90, I think he would need a right thoracotomy urgently. And from the CT scan, I didn't see lots of blood in the belly, but it was non-contrast, and I agree with laparotomy in this patient. Laparotomy would be safest approach to rule out the intra-abdominal injury in this patient. And I also think the patient would need right thoracotomy too, because he has persistent air leak. Since he was saturating well, I would go with the laparotomy first. And then if the air leak still persists, I would think about the right thoracotomy. And if the patient is stable enough, I would ask the anesthesiologist to put the bronchoscope to the right bronchus to check for the point of air leaking. Thank you very much.
Thank you, Dr. Super. Dr. Barros, your turn, please.
Yes, thank you all. So what we did, we went to a laparotomy as you manage. And what we saw at the beginning, we had a moderate amount of blood, free blood in the peritoneal cavity. And after the compress removal, there was no active bleeding. Well, we saw the disruption of the liver parenchyma between the cranial segments 7 and 8. There was a lesion in the diaphragm about 8 to 10 centimeters of extension. There was no blood clots and blood coming from the chest. What we did was close the diaphragm with a continuous suture. We drained the belly with one drain above the placed above the liver, another one under the liver. We put another chest tube to contemplate the pneumothorax, and the patient during the procedure received 3 blood concentrates and more 3 plasmas. The duration had 55 minutes. The decision to disc enclosure, the heart rate at the end was 100, 110, the saturation 98%, and the systolic blood pressure at the beginning of the surgery was 80, and at the end 110. Does anyone want to comment about this approach, Patricia?
Dr. Epstein, can you describe your experience with?
Yes, I like the approach. Actually, I should have mentioned it before. You can look at the lung through the liver. That's a pretty big laceration of the liver. Was there any idea what size caliber this was? And the other go ahead, I'm sorry.
No
idea.
We didn't.
And the other possibility that was he intubated with etomidate at the other hospital? And again, you don't know, but sometimes etomidate can suppress the adrenal and cause a bit of a transient hypotension. It does take some time, but now you're a couple of hours into this. So I would probably have given him some corticosteroid. It doesn't hurt to do 1 dose. But otherwise, I think you've done perfectly.
Thank you, Dr. Epstein. Dr. Kassim, would you like to make any
Very
comment?
good thought. Yes, etomidate does cause adrenal suppression, but it is rare. But it is something to keep in mind. Very good thought. I agree with Dr. Epstein. I would have done little different to the liver, and I would have mobilized the omentum and put the omentum over it and see if I can cover it up. Just putting a chest tube alone may not be sufficient, and I would be anxious that this may cause this patient may have postoperative leakage, either blood or bile, and perhaps he should get some type of a tamponade, either packing it or omental coverage to this ugly-looking liver. Certainly would not do any liver resection in a case like this. And you can, like Dr. Epstein says, you can have a little peek into the chest cavity through the large rent in the diaphragm. And you can actually pull the lung down and have a look as well sometimes, right low, see if there is any injury there. You need to have a working chest tube to be able to benefit the patient. So I agree with what was done, and I want to stress to my young surgeon there, try to avoid giving crystal oil to trauma patients. That's an old school. We all have the mindset of giving crystal oil every time we see a patient who's hypotensive. By the way, you don't need a blood pressure of 110 when somebody is bleeding. 90 to 95 is sufficient. And again, you should tell your anesthesiologist not to get tempted to give more fluid or more blood to get the blood pressure sky high, because it only causes. Thank you.
Thank you, Dr. Kassim. Dr. Antrak, would you do something different?
Well, I think that they did fairly well, and I assume you ran the bowel carefully, made sure there was no evidence in the duodenal injury, especially since the bullet went near there, and it would be retroperitoneal. So I might actually look carefully, and if there's any question, I would maybe cocarize the duodenum, look both posteriorly, but and I might have left a second drain between the liver and the that rent in the diaphragm above and below, just to get adequate drainage. But basically, what you did, I think, was fairly good. Also, but before closing the rent in the diaphragm, maybe you did this, and I missed it, but you can easily clear out all that blood that had been collected. It's sitting just on the other side of that rent and posteriorly. And then I think what might have happened here, because he was 90 minutes in the other hospital, given only one liter of crystalloid and no blood, right? Just 1 liter of crystalloid. And then I don't know what he got the 90 minutes in transport to you, but until he got to you, really, you gave him what, one unit of packed cells first, and then 3 in the OR. So it looks like it might have been an incomplete resuscitation, and he just needed better resuscitation because he wasn't pouring out blood from anywhere, and there was no active bleeding that you needed to stop, and he still needed to be explored anyway. But that might have been the issue here, that just because of the time from the gunshot till he got to you, he was just fell behind in the amount of resuscitation that he had. So. And then there's the other issue that Dr. Epstein raised, perhaps adrenal insufficiency. I wouldn't have thought of that, but that's also a possibility.
Thank you, Dr. Antrak. Dr. Supra, would you like to make final comments?
Yes. In this patient, I think if he is still bleeding from the raw surface, if he has also coagulopathy and hypothermia, I would leave the packing inside the abdomen and do the temporary abdominal closure, damage control surgery for the abdominal part. And after we finish with the abdomen, I would reassess the chest tube output after we put the second chest tube in. Was the air still leaking? And how was the patient saturating? If I still have concern about bronchial injury, I would ask the anesthesiologist to put in the bronchoscope to check the right bronchus, and he may need right thoracotomy. Thank you.
Thank you, Dr. Super. Dr. Barros, please.
Yeah, thank you all. Just answering Dr. Antrak.
Patricia, Patricia, someone raised the hand.
Yeah, I can see. Dr. Michael Wetterly is asking something, please.
Hi, this is Olivia. I'm a trauma surgery PA. I just had a question about the transient hypotension y'all mentioned with the etomidate, and you would use steroids. Can someone explain that a little bit more? I haven't seen that in practice. I'd like to learn.
Thank you, Dr. Wetterly.
I'd be happy to answer that. There is more than adequate literature. In fact, something published from China just last month that etomidate can suppress the adrenal gland, and you don't have your corticosteroids to help with maintenance of blood pressure. It doesn't always occur. It's not always obvious, but it's a consideration when you can't resuscitate someone where everything else seems to be in order.
Thank you. Dr. Barros, your turn, please.
All right. So we had only these lesions, no damage in the retrocavity. And after 5 hours after the surgery, we had such a small improvement in the blood gas test. We had already a biofistula, as you can see in the image. The day after, the patient vital signs were blood pressure 110 of systolic with norepinephrine low doses. The saturation was 98, still with 2 test tubes. Heart rate was 126. The drainage, the thorax, the output were 500 milliliters of hepatic fluid, and with a continuous bubbling. Liver, we had a 300 milliliters of bile, and the inferior drain, the Blake drain, had collected 35 milliliters of bile. This is the RX 1 day after the surgery. You can see a big area of contusion, and we still were concerned about some bronchial lesion due to the patient kept with a continuous bubbling. We had already another blood gas test with some improvement, and this was our actual concern, how to treat it. And we decided to add another jar and connect it to a suction, to trying to expand the parenchyma and see how this would disinvolve during the week. 2 days after surgery, we still had bubbling, even connected in the aspiration, but we had a good improvement in the blood gas test. As you can see, no more acidosis or a compensate 1 pH. The base excess had diminished, the lactate levels a little bit better. This is a peripheric lab test with 11 of hemoglobin and some increase in the renal function. That's a follow-up during the week. The patient had decreased his inflammatory and infection markers. The drain, the thoracic drain, reduced his blood output. At day 5, we had only 100 milliliters of blood. Actually, it was cytomatic this time. The liver drain keeps with this output of 300 milliliters of bile. And our problem were the thoracic drain with this air leak, continuous air leak during the positive pressure ventilation. And we did a CT scan to investigate what was happening in the chest. At this time, we removed one of the chest tubes to connect another jar in the continuous aspiration. That's why you can see only one chest tube. And here in another series. Still with a pneumothorax, subcutaneous emphysema, an area of contusion. If anyone wants to comment these CT scans, Patricia, please.
Mhm. Dr. Antract, can you please make a comment?
That chest tube, could it be intraparenchymal? You know, and that's the air leak, or is it just in one of the fissures? But that's my concern, that you know, the position of the chest tube, and then otherwise, you know, it's not working effectively. It's not expanding the lung, and it doesn't seem to. It might not even be in the pleural space. But that would be the first thing I would wonder about, and then I would, you know, try to assess: is it really? Could it be intraparenchymal? And I guess that's kind of hard to do if it's just sort of passed gently through. But just by the way it looks, it seems to be surrounded by parenchyma. It first appears in the parenchyma, and it's surrounded by parenchyma, and then you know, as Dr. Supa said, you know, you need to do a bronch to see where the air leak might be, but a continuous air leak with a lung not expanded, as Dr. Supa said, is an indication for a thoracotomy. But otherwise, you know, you are ventilating him reasonably well, and he's improving. So, you know, you have a little bit of time to sort things out.
Thank you, Dr. Antrak. Dr. Supa, would you like to make any comment?
Yes. This patient at this point, I have two concerns. Number one is the infection. He has high white count, and I think he's still in sepsis. And I would like to rule out the treatable cause in his abdomen. So I would check his abdomen thoroughly. I would perform a formal CT scan of the abdomen. He may have like a missed bowel injury, duodenal injury, and something bad in the abdomen. So he needs formal CT scan of the abdomen. And the second source is the thoracic esophagus. I'm a little bit concerned because he may have transvaginal gunshot wound, and we didn't assess the esophagus. He has a lot of pneumomedicinum at this point and sepsis. So it wouldn't hurt him to do the EGD to rule out the intrathoracic esophageal injury. And the second thing is he has air leak on the right chest, which I would go with a bronchoscopy to check the position of the leakage and to plan the surgery. Thank you.
Thank you, Dr. Supa. Dr. Epstein, would you do something different?
I would. I agree with Dr. Untrack that may be in the parenchyma. I should have mentioned earlier, you know, when you position a chest tube, you put it in with the abdomen open and the diaphragm open so you can guide it along the chest wall. That's the first thing. And if you take that chest tube out, and you can either ask IR to do it or you do it under fluoro in the ICU. I know that's a bit radical, but I would change the position of the chest tube and then see what happens before I became any more radical. And I would have sutured the liver, by the way. I should have mentioned that. I assume that the surgeons did do that, either with omentum or a hemostatic packing, or just pack the liver, but I wouldn't have left it open.
Thank you, Dr. Epstein. Dr. Cassin, would you like to make a final comment?
Well, a couple of things.
Mm-hmm.
Like Dr. Supra mentioned, you rule out any abdominal pathology, and he's had significant leakage of bile plus blood product from the liver injury. And you make sure that you're not dealing with subphrenic abscess from the liver injury. Unlikely. So the money is going to be in the chest. So what the patient has is a bronchopleural fistula. And I think you should routinely check out the esophagus and check out any other areas in the mediastinum that could be causing the problem, because those are very easy to rule them out. You know, you either do an endoscopy or contrast studies or whatever you want to do. Looking at those chest tube bottles remind me of what they used to do in England 50 years ago when I was in training there. We don't do that anymore here in the United States. And but I think he has a bronchopleural fistula, and there are two ways of treating bronchopleural fistula. One is to wait it out to see what the patient does. That's what they used to do in England years ago. And then second would be, like that Subra mentioned, you do a thoracotomy and go and fix the air leak, either with the staples of sutures of resection. So, in my opinion, conservative treatment probably works in cases like this. So don't rush into the thoracotomy. Give the patient some time to heal. And he's got a significant skin necrosis of the anterior chest wall there. So, you know, those things are bothersome. You, more often than not, that I find these type of injuries, they heal if you give it some tender loving care. Thank you.
Thank you, Dr. Cassim. Dr. Barros, your turn, please.
So since we had, as you mentioned, this skin necrosis, we thought that this patient could be treated with a thoracotomy. And if you look again, the tomography, you can see such a part of the parenchyma herniation through the soft tissues. And there is a part of the parenchyma with a white sign. It may be infection or necrosis or consolidation, damage by the bullet. We didn't know, and we decided to do a right thoracotomy.
Hamilton?
Yes.
Yeah, basically the indication of thoracotomy was the necrosis and the herniation.
Yes.
You mean the herniation through the necrotic skin?
Exactly.
Okay.
So
we did a right anterior lateral thoracotomy. We did the debridement of the dead tissue, the soft dead tissue. We did a segmental lung resection with the linear stapler. We sutured the alveolar leak, reminiscent, and closure, and we closed the thoracic wall. I'm gonna show you the video of the parenchyma lesion. This picture, the second picture, is after the surgery. That's what we got in the chest wall. This was a big challenge to close. Here's the initial lung aspect. This part is the inferior third of the upper right lobe. We had a destruction. You can see the tract of the bullet, a hole in the right side of this part. There is some necrosis of the parenchyma. We assumed that this was a peripheral lesion causing this pneumothorax. And this was the final aspect of the lung after the segmental resection. and the evolution the days after. So we had this surprise, some biopleural fistula happened at the day 2 after the thoracotomy, but was spontaneously solved in the day 7. Well, we had the blood gas improvement. The patient was, we had to do a tracheostomy since the time the oral tracheal tube, he had already 16 days. We did the removal of the chest tube after the thoracotomy in the day 10, and the patient in the day 14 were with no sedatives and already awakened. This is an X-ray after the removal of the chest tube. Still an area of contusion, but better than the initial one. And we did a tomography after the 15 days after the surgery.
Not going, not working.
Working. All right. We could achieve the parenchyma expansion. You can see a bilateral consolidation, maybe some pneumonia, nosocomial pneumonia, have been treated with antibiotics. No liquid or pleural effusion. The upper abdomen, we can see. The intention is to see in what the chest. And so, as I've mentioned, our biggest challenge was to close this chest wall. We had a big area of necrosis. We had to resect the muscular tissues, soft tissues in the skin. We had a bad evolution after the surgery. We did a bedside, resutured bedsided 2 times during these 30 days, but the patient kept with a normal ventilation patterns. We could treat it in a conservative form, and this is the final aspect. 10 days ago, the lesion is basically closed, but was really difficult to manage this bedside. So now, Patricia, let you free to ask the doctors about this approach.
Dr. Epstein, would you like to make final comments, please?
Certainly. I think it's a tough case, especially looking at the skin there. I probably would not have sutured the wound when he came in. I would have taken it, I would have sutured it in the operating room when I did the abdomen. That might have helped. You could have pulled some ribs together with some heavy suture and then close the skin, and you might have underlying muscle without any worry for hernia. The skin would probably still have necrosed from the gunshot wound, but otherwise I think it's great. The other thing I might add is he should be ventilated with very low volumes if you really suspect a bad bronchopleural fistula. and extubated if possible. But the outcome is the outcome, and it's great.
Thank you, Dr. Epstein. Dr. Kassim, would you like to make final comments, please?
Well, you can argue with about good outcome, okay? And what are the things that I would have done different? And I agree with Dr. Epstein. Don't suture the primary wound, because you're always tempted to suture it, but you will pay a price for it because it's all infected. Second, when you have something like this of this magnitude, you need to employ nearby tissue to cover it up, or use prolonged wound vac treatment at a low pressure to see if you can get the granulation going and allow the granulation to occur so that you can cover it either with biologic or skin graft. But you can, like I said, you can argue about success. It was the surgeons who treated this did their best and got the best result. A good educational case. Thank you.
Thank you, Dr. Kassim. Dr. Antrak, a final comment, please.
Yes, so very, very nice case. I take it that the by the way, my picture was off because I was breaking up before, but let's see, let's try that. The intra-abdominal bile leak, I assume, just stopped on its own, and that's often what happens. If it hadn't, then you'd have to do the usual investigations, maybe ERCP or a HIDA scan to see if there's an active leak from the biliary tree. But that usually is what happens with these leaks. And despite everything, despite the 90 minutes at the outlying hospital and not perfect treatment because they just don't have the experience, and the 90 minutes to you, and probably a lot had to do with the patient being only 22 years old, that he was able to tolerate the hypotension for so long. But still, despite things not being perfect, you're able to get a successful result. And I think that was all due to the good judgment that you used. After you explored the abdomen, you were pretty comfortable with what you saw. And then the problem was the persistent air leak. And as Dr. Supa pointed out at the very beginning, that's an indication for a thoracotomy, and it was the right decision. You found the problem right away and you fixed it. So, my hat's off. I mean, that was the main part of the case. Those judgments, which you did perfectly. And these are other, the small bits around around the edges that. You can. I think they're very good comments that my colleagues made, but well done. And for a PGY2, I would have said you're at least a PGY5 or first-year fellow, but you did good on this case.
Thank you, Dr. Antrak. Dr. Supa, any final comment, please?
Thank you, Dr. Barros, for presenting this very well-managed case and very interesting. May I ask what type of gun the patient got shot with, and what type of the bullet? Do you have any idea about that?
No, unfortunately not.
Because I think the injury to the liver and to the chest wall is quite severe. It's not a usual handgun, I believe. Maybe it should be some deformed bullet that cause high energy transfer to the patient and cause this type of injury. But thank you very much for presenting the case. I learned a lot.
Thank you, Dr. Supa. Dr. App, thank you all for your presence during the Labor Day. Dr. Ramos or Dr. Barros had any consideration?
Yes, there is just one final page. The patient is still in the semi-intensive care unit. Unfortunately, he's suffering from this long stay in the hospital. He's under replacement renal therapy, but in better conditions during the evolution. He fight against nosocomial infection, pneumonias, in treatment with antibiotics. And the biofistula, we had a problem. We indicated retrograde cholangiography, but this patient, he's under police custody. And
Yeah, he's arrested.
Yes, he's arrested. So there is such a maneuver, a military maneuver to transfer this patient to another hospital in order to do the cholangiography. So we're trying to treat this in a conservative management, and it's going good. The biofistula yesterday were 100 milliliters per day, and probably it's gonna be closed anytime. Dr. Ramos?
And he was doing daily dialysis. Now they're able to do it like 3 times a week. And Dr. Supa, we work with very heavy guns in here. It's kind of like a war. So gunshot wound, like a handgun, no, we don't have that. And Dr. Ontract, we have that kind of problems here that sometimes we can't do an exam that we want because we need to transfer. And since he's arrested inside of the hospital, they don't transfer him.
Thank you, Dr. Ramos. Dr. Ontract, please.
Yes, very, very quick comment. So I guess it's been more than 2 or 3 weeks now in the biofistula. If you can't do any other study at the bedside, you can do a fistulogram with gastrographin through the drain, and if it lights up the biliary tree, you know, but there's no collection, then if you just keep it there and gradually withdraw the tube, the drain, then the fistula will close, almost like a T-tube. You know, it could be like a T-tube that you put in the bile duct. And but if there's a big collection of bile outside the tube, then he would need interventional radiology to drain that collection, and the fistula will close. As long as there's not a disruption of the biliary tree, you should be able to manage it conservatively, even without the ERCP.
Thank you, Dr. Ontract. Any panelists would like to make any final comment? No? Thank you, Dr. Ramos. Thank you, Dr. Barros. It was a pleasure to us to have you with us today. Have a wonderful Labor Day, everyone. Thank you.
You too, Patricia.